thanks all of you all for coming today. I really appreciate the invitation to speak as part of the Neurotrauma session. We're going to stay in the realm of TBI today, and or at least this portion of today's program. But I was really thrilled to see the focus on spinal cord injury for this year's symposium. It's really great to have that focus this year, and so you'll be hearing a little bit about some spinal cord injury myself and some colleagues are working on to bring to our neuro ICU in a subsequent talk by Anastasia Keller. So I'm really looking forward to her talk. So please stick around for that. But before we get there, let's go to some ways in which we can assess physiology at the bedside. I will lean heavily on some of the great work that Jeff has done for many, many years in our neuro ICU, and some of the ways in which we're trying to bring back some of the things that we can do at the bedside to assess our patients. And when I say we, I don't mean just the doctors and the NPs. I mean very much the bedside nurses. This is an us situation. And so I just want to encourage and empower all of us at the bedside in the ICU that these are things that all of us can do. And so as you hear this talk today, I very purposefully did not put in like 55 slides in order to encourage you to ask questions and to stop me. Of course, at the end, there will be ample time for questions. So a lot of what I'm going to talk about, even though I'm saying physiology and it's going to be like a review in some instances, certainly for many of you in the room, is to really encourage you to think through some of this physiology. I was very much attracted to ICU medicine, even though I'm such a neuro nerd, because of this physiology and because I love thinking through these pieces. And I think many of you feel the same, and that's why you're attracted to work at the bedside in the ICU. So again, some of this is going to be review, some of this is thinking about it in a new way, but all of us can do this, and we can solve problems at the bedside by just kind of going through these steps. So I'm going to bring up some cases. I was just on service this last week, finishing up yesterday, and did some of these things very much to help me to problem solve at the bedside for some very real cases just like moments ago. So let's get started. First off, again, review. I know for many, if not most of you in this room, the one thing that's so unique about the brain is that unlike every other part of our body, pretty much, when you injure the brain, you just can't sort of swell out into the air like you can with your arm or your leg. The brain is in a rigid, fixed, enclosed space. And so when the brain starts to swell, something else has to give, and oftentimes that's blood or CSF up to a certain point, at which, unfortunately, unless you open that skull with a surgery, things start to be forced down into the sort of the foramen magnum, and you get a herniation syndrome, which, as you know, is life-threatening. And so as I think through, and I'll go through some of these equations, you can sort of reason through what we see clinically at the bedside. So just generally, the brain occupies approximately 90% of the intracranial volumes or contents, blood at another 5% approximately, and then CSF about 10%. And as you displace or change those contents, either with, for example, expanding hematoma or a brain tumor or anything else that kind of shouldn't really be there, and it's going to start to compress and displace the other parts of those contents. And so a lot of the things, again, that we observe, physiologically and at the bedside in our patients that have been injured, particularly in TBI, but really in any other neurologic condition, fall out of those basic principles. So keeping that in the back of your mind as we start to observe our patients with different pathology. The next piece is something that we uniquely see in patients that we're able to monitor their intracranial pressure, whether that be with an extraventricular drain or with a fiber optic pressure sensor, like the direct link, sometimes with both, are intracranial pressure waveforms. And so in A, pictured above, and I actually do have a laser pointer, so that's handy. All right. And so an A is a typical waveform in a compliant brain. And so I liken the brain, and this is very strange for a neuro person to liken the brain to lungs, but in the top compliant brain is a distensible elastic brain. And that's a typical situation. Hopefully all of us in this room have a very stretchy elastic brain. And this corresponds to the cardiac cycle. So in a beat to beat fashion. So in each cardiac cycle, you'll see this waveform displayed on either the EVD tracing or the directly tracing. And so this is systole, and so the aortic blood is rushing into the intracranial vault, and for just a microsecond will displace some of the intracranial contents. And you'll see that P1 that is also termed the percussion wave. And that makes sense thinking about the percussive nature of the aortic blood rushing into the intracranial vault. P2 is the tidal wave, perhaps named because it's the cerebral spinal fluid rushing back in since it was displaced just for that millisecond from the aortic blood pulsation. And then P3 we don't always see. It corresponds to the closing of the aortic valve, or it's also called the dicrotic wave, sort of like the dicrotic notch that you can or don't always see on an EKG, again, with the closure of the aortic valve. So this is a typical elastic compliant brain, and this is what you're hoping to see in your intracranial pressure waveform in a typical situation. B is a situation that we unfortunately see a lot in our non-compliant situation, in which a patient has a stiff, wet, boggy brain tends to be observed in a non-compliant system when a patient has, for example, a lot of cerebral edema and just does not have that elasticity. Liken that to a patient with like ARDS lungs. It's very hard to ventilate because they have stiff, wet, boggy lungs, and it's hard to force air into them. Very similar situation in the brain. Very hard to force blood up into that intracranial vault. Very similar situation. So when you're looking at a waveform like this is the patient that I'm scared to go send down for a total MRI brain spine and lay flat in the tube for 2 hours. So it's really useful for us, certainly on rounds, to go in and clamp that EVD and just take a look at that waveform. And for you all, when you're transducing ICP, whether it's clamped all the time or if you're just doing clamping hourly, to just take a look at that waveform and just make a mental note of what you're seeing. And then also if it's dynamic over hours. So this is absolutely something that you all can do at the bedside, is just notice, is the waveform changing hour to hour? Are you seeing a progression of the waveform, or is it somewhat constant between assessments? And that gives you a sense of where you are on this pressure curve. There's a nonlinear relationship between intracranial pressure and intracranial volume. Most of us, hopefully in this room, are living in this situation in which very large changes in intracranial volume do not represent large changes in intracranial pressure. However, a lot of our patients that are in this situation where they're hanging out in this part of the curve, it's sort of like a Starling curve, thinking about the cardiac sort of physiology, in which very small changes in intracranial volume result in very large changes in intracranial pressure. And so they could get into trouble really, really fast. And looking at that compliance, those beat to beat changes on the ICP waveform can give you a sense of where you're living. Sorry, this laser pointer isn't very bright, but it gives you a sense of where you're living here, kind of closer to 1, or if you're hanging out closer to 3 or 4 and could get into big trouble. These are some equations that govern some of these relationships. I'm certain that many of you are familiar with the top equation. So this is the cerebral perfusion pressure. This is calculated by taking the mean arterial pressure and subtracting the intracranial pressure. And so it's pretty intuitive that if you have a low blood pressure, very high intracranial pressure, that your perfusion pressure would be pretty low. And so we raise the blood pressure or lower the ICP to maximize the cerebral perfusion pressure. That underlies the idea that to get blood flow or cerebral blood flow, you take the cerebral perfusion pressure that we've just calculated and divide it by the venous resistance. This idea gets incorporated with the idea that if you block venous resistance, for example, maybe you have IJ lines or something that's increasing vascular resistance, that can reduce your cerebral blood flow. But finally, at the end of the day, what you really care about is oxygen delivery to the tissues. And that's calculated by taking the cerebral blood flow and multiplying it times the oxygen carrying capacity of the blood. This is where things like a low oxygen saturation in someone who's hypoxemic or in someone who's very profoundly anemic, that's when that comes into play. So this would be the way we could modify this would be, for example, to transfuse someone or to optimize someone's oxygenation status by, for example, making ventilator changes or something of this nature. So that's where that comes into play in terms of optimizing oxygen delivery to the tissues. So these are some of the equations. So I know it kind of gets boring into the math, but this is sort of what we're thinking about, which underlies some of the principles of some of the changes that we might make in someone's clinical care. A few more words on cerebral perfusion pressure because it's so ubiquitous in terms of what we do. As you know, oftentimes a standard goal at the bedside would be 60 to 70, but that's not going to be a one size fits all for all of our patients. There are times in which we would customize that cerebral perfusion pressure based on that individual patient's physiology. And a lot of that would have to do with whether a patient is autoregulating or not. And we would assess that at bedside. Most patients, not all certainly, but many patients autoregulate and have that intact, but not all brain injured patients have an intact autoregulation system. And I'll talk a bit about that in the next slide. But in general, CPP is recommended to sort of be in this threshold, but I just wanted to say this can be customized based on the clinical scenario. I want to say a little bit about autoregulation. This is the classic relationship between these two things, but essentially autoregulation is the idea that the brain wants a constant state of blood flow, no matter what you're doing in terms of your body position or your activity level. And so, for example, this underlies the principle that you can do a handstand and not pass out or change position because your body's able through the autonomic nervous system to continuously send signals to blood vessels to vasoconstrict and to vasodilate, depending on what you're doing, if you're exercising or changing position or sleeping, this type of thing. So for many of our brain injured patients, that autonomic nervous system signal is disrupted in such a way that, unfortunately, that blood flow does not remain constant and it's dependent on the blood pressure. And so if we see that the two of those things are in lockstep together, meaning that the intracranial pressure and the blood pressure go up and down together without changing in an inverse relationship, that makes us worry that autoregulation has been lost. And I'll talk a little bit about how we detect that in subsequent slides. But essentially what we're expecting when autoregulation is intact is those different principles have sort of an inverse relationship to one another. And you can kind of see that on the graph behind me. These are some of the ways in which we can detect autoregulation. That can be done. Essentially, what we're looking for is a cerebral blood flow surrogate. It's hard to measure cerebral blood flow invasively. We can do it. There are monitors out there. There are weaknesses of those, kind of beyond the scope of this particular talk, but there are invasive and non-invasive ways of doing that. For the most part, what we do clinically at San Francisco General is we rely on the ICP and measures that arise from the ICP. The main one that we look at is one that's called PRX, and that stands for Pressure Reactivity Index. It's something that we use our Moberg monitors to help us to measure. Essentially what it is a moving Pearson's correlation coefficient between the arterial blood pressure, specifically the systolic and the ICP. And so what this is that those two quantities really should not have a relationship to one another. They should either be inverse or have no relationship. So if their correlation is 0 or a -1, that's normal. And if you see on this graph below, -1 to 0, that's normal. That would represent an intact autoregulation. If it's positive or closer to 1, meaning that the arterial blood pressure and the ICP are basically doing exactly the same thing, that's terrible. That's not what you want. That would be abnormal and indicate to you that autoregulation is not intact. You can also ascertain this by doing a blood pressure challenge, which we'll talk about in subsequent slides. You can actually plot PRX, and this is done on the y-axis here, along with the cerebral perfusion pressure and try to determine an optimal range of when that PRX is the most normal, i.e. most negative, closest to -1, and find the range of CPP in which a certain patient is quote unquote happiest. And that's termed an optimal CPP. Now, we don't have the ability to do this in an automated fashion yet, but have big dreams. So there might be someday where we can do this in a pretty semi-automated way and find out where patients live in a more precise, sort of a more precision medicine sort of paradigm. So this is the dream. I hope we're going there someday. But that's what many neurointensivists sort of like. When we fall asleep at night, what do we think about? CPP opt. All right. Maybe that's too much information. So let's talk a little bit about, I want to cover 4 maneuvers that we can do at the bedside to interrogate a specific patient's physiology. Some are quite simple, some are a little bit more sophisticated, but I want to encourage you, certainly in conjunction with the clinical team, that these are things that you can do to try to get physiologic answers about your individual patient. The first one is the jugular venous compression test. And so in this one, you can just simply put pressure over the neck. And what that does is impairs jugular outflow. Now, obviously, don't obstruct the airway. Don't go crazy, but just for a few seconds. And what that should do is to increase the intracranial pressure. And you should see a requisite increase in your monitors. And so what this can help you to do is to see if your ICP monitors are functioning. There are times in which we see poor waveforms, like on our EVD or our direct link, and we were all wondering, is the monitor even working? For example, we had a patient just the other day who had terrible intraventricular hemorrhage. We were wondering, like, is the monitor even working? And so this was a quick way to just see, does the ICP rise? And in fact, it did. So that was really reassuring. So if ICP precipitously rises, it suggests that, particularly if it shoots up, it can also suggest that compliance is poor too. So you can get a lot of information from just simply doing that kind of quick compression test and sort of seeing kind of what information you get, as well as if your monitor is measuring what you think it's measuring. The next of which I alluded to just a moment ago, which is the pressor challenge. This is another way to see if autoregulation is intact. And so here, in conjunction with the clinical team, you can raise the blood pressure, usually with a vasopressor. You can do it with fluid boluses, of course, too, but usually with a vasopressor. And usually about 10, 15 millimeters of mercury above baseline, and to see what the ICP does. Now, in folks with intact autoregulation, the ICP really shouldn't change, right? You should be able to vasoconstrict and to maintain a constant ICP. And those with impaired autoregulation, the ICP really should, it might increase, and that would be suggestive of impaired autoregulation. Here again, just sort of reminding you what that autoregulation graph would look like. So that's a way that, the NPs and the neurosurgical clinical team does this very, very often with their autoregulation challenges. And so this is what they're thinking. And you can see the graph there on the side with this particular physiology. We don't do this as often, but you can also do a PCO2 reactivity test. And so essentially, we hyperventilate sometimes when we get in trouble with elevated ICP. Similar idea here. You can do this electively, in which you raise the respiratory rate. And by doing this, you blow off PCO2. So you change the PCO2 levels, reducing the end-tidal CO2. This changes the pH of the blood. And that actually vasoconstricts, and this will reduce ICP. And so this is a vascular reactivity test. And again, you should see a reduction in ICP. If you do not see a reduction in ICP, this would suggest that the cerebral vasculature is maximally constricted already, and the brain is like right on the cusp of ischemia. So that would be a danger sign, that the patient is like all the way maximally sort of like at the cusp of what it can do to compensate. So that can be kind of a way of seeing, sort of where you are and the brain's ability to compensate. This is a diagram from a physiology paper just showing how exquisitely sensitive vessels are to the degree of capnia. This is another kind of reminder of how vessels can vasodilate pretty profoundly to higher PCO2s. So this is why we get very obsessive about ABGs and the PCO2. So you'll hear us on rounds kind of obsess about this a little bit. And then finally, I just want to talk about the pressure equalization test. This is like a San Francisco General original, originated by the group here. I was not involved, but this is a really amazing way to get an insight as to whether the dominant physiology is due to hydrocephalus versus cerebral edema. And essentially, this is an equation that's derived by observing the change in ICP over the change in ICP that you would expect. And so it's essentially taking an initial ICP and then clamping the EVD for a period of time, and then taking a final ICP and looking at drainage. And this is from the original paper, and these are the two types of patients that they looked at in this case series. The top was a patient with TBI. Dominant physiology here was cerebral edema. You can see how much edema and swelling there. And in the bottom was an aneurysmal subarachnoid hemorrhage patient that had a ruptured aneurysm. Dominant physiology down here was hydrocephalus. And in general, the pressure equalization ratio closer to 1 would be suggestive of hydrocephalus as the dominant physiology here. And then closer to 0, cerebral edema as the dominant physiology. And so we won't go through the equation in depth, but essentially this is a way to kind of ascertain like what the dominant physiology is there. And then finally, my last couple of minutes, where I'm going with all of this is as this is a useful clinical tool to kind of help you to know what's going on with your patients, to interrogate your monitors. But we're going to be applying this in the context of a research study as well. Many of you might know that optic nerve sheath diameter measurements are gaining some popularity as a surrogate for intracranial pressure monitoring measures. There is, in fact, enough literature to actually do a scoping review of the papers that have come out up to this point. This review just came out last year from a group. But the reason that folks have been interested in using optic nerve sheath diameter as a measure is that optic nerve sheath is contiguous with the rest of the central nervous system in such a way that if you measure this quantity, and I'll show you where exactly we measure, you can get a sense of what's going on with the rest of the central nervous system. If you imagine holding a water balloon and squeezing it, the balloon filled with water will bulge out of your hands. Kind of a similar idea. The harder you squeeze, the bigger that balloon will bulge out of your hands. So that kind of principle underlies the principle of using optic nerve sheath diameter as a surrogate for intracranial pressure. So this is the way it's done. This is a schematic of what the optic nerve sheath diameter looks like in sort of cartoon form. And this is what it actually looks like on an ultrasound. So here is the eyeball. And this is the optic nerve sheath diameter. Here's the actual optic nerve itself. So we just non-invasively go right over the eyelid and put the ultrasound probe right here. It's not painful. Several of us have done it on each other, so it's something bored on a Saturday night. This is what we do as neurointensivists. We're really a fun group, you guys. I'm telling you. So you 3 millimeters back from the optic nerve head. And then you measure from here to here. You can kind of hallucinate that there's an optic nerve sheath right here. And there are some general cutoffs, but one of the big weaknesses to this technique is operator variability. Just tiny little movements in your hand lead to big changes in these point something millimeters. And so we've partnered with GE to help them to not only develop a brand new 3D probe, kind of similar to the 3D cardiac probes, as well as to develop some AI augmented software to help to reduce some of that interoperator variability in order to bring more reliable measurements into, optic nerve sheath measurements into, kind of broader practice. So to start out with, we need to first start with patients with gold standard ICP monitoring first. And so that's what we're going to be doing. So we plan to open this trial here right after the holidays in the new year. So you'll be seeing us do this more and more. We're starting to do it clinically. I think several of you have seen our optic nerve sheath pictures in the charts. And so coming coming to you soon. And I'm going to stop there. So thank you so much.
Any questions? You mentioned the optic sheath diameter measurement.
Yeah.
Will patients with orbital trauma be excluded from that, or does that have any effect on it?
Yeah, I mean, anyone with orbital trauma, we specifically have to avoid. So definitely, yes.
Is that any orbital trauma or just?
Yeah, so they have to have an structurally intact orbit. So yeah, so we can do the contralateral eye. That's fine. If both eyes are injured, then that patient can't be involved. Yeah, clinically or for a research study.
Thanks for a great talk. I'm always find myself a little bit perplexed by the utility of PRX in an ongoing kind of basis, because, you know, when you look at the trend line that you presented to us, the trend line itself is all over the map. So how do we determine when that information is useful and actionable?
I think that's an important question. I don't know that any one individual patient will never never have values outside of range. I think that the way I can say how I've applied it personally, and I don't know that, you know, this is my own personal opinion, but I'll look at the amount of time that someone's out of range. And if that's increasing over days, it kind of makes me worry. The way in which I've used it, that I found it clinically really helpful about a year and a half ago, we had a woman who started to have increasing time periods in which her PRX was really out of range. So it's like 20% one day, and then suddenly it was like 50%, and then suddenly it was 80% the next day. That's right. It was like the dose of out of range was increasing, and then her exam was worsening. And then eventually we found that she was in post-traumatic vasospasm. And that was the way that we detected it first. That was the earliest indicator for us, was that. So it can be an early detection system that something's physiologically wrong, but it's nonspecific. And so, you know, it has, in and of itself, it's, it has to be put in the context of like other signs and symptoms.
Just to comment on that for a second, the fact that it is variable and it changes suggests that we need to be looking at the patients more frequently and more closely assessing them, which is why we want to try to bring back this bedside physiology, because just to criticize us, going around at 7 o'clock in the morning looking at the patients, they're there 24 hours a day and they change a lot. I mean, that one patient that we were taking care of on Friday was changing all the time. And that patient also, we kept on trying to think about, like, well, when are we going to potentially do a decompressive hemicraniectomy? We did 2 days in a row, measure the optic nerve sheath diameter. So it's like all these things that we do. There's not one thing that we look at. I think we're just trying to increase the size of the toolbox like they have over in the cardiac care unit to have more things to try to do this. But I think when you see that change so much, it just tells you it's incredibly variable, and one needs to always be thinking, well, what changed? Because for our colleagues in Cambridge who really came up with this idea of PRX, they have a system where it's like literally red light, green light, yellow light, and throughout the day it's like Christmas lights, right? I mean, because people are coming back and forth all the time, changing. So it's just something for us to be mindful of.